So thank you everyone for coming. We're excited to have you here and we're really excited for our two presentations today. So the first one is by Rami, and he comes to us with a bachelor's of engineering and a master's in biomedical engineering, and now is a medical student at the University of Toronto. And his past research experience includes EEG-based brain-computer interfaces, surgical robotics, and most recently using vocal features as a marker of neurologic conditions. And I'm really excited to hear about his project on machine learning assisted swallowing assessment, or probably easier to say MASA or MASA. So I'll let you take it away, Rami. Thank you.
Thanks, Gemma. Hello, everyone. My name is Rami. I'm a soon-to-be third-year medical student here at U of T, and I've had the pleasure this summer and last summer, through the support of T-CAIREM and Sunnybrook, to work on the machine learning assisted swallowing assessment, or as Gemma said, it's easier to say MASA. So with that, I will get started. So just a little bit of background. So stroke is a serious medical event, and there's two primary etiologies for stroke. There's what's known as an ischemic etiology, where a clot in one of the major arteries of the brain can lead to ischemia and even necrosis of brain tissue. And there's also hemorrhagic stroke, where there's a rupture of a blood vessel. And in each case, there can be serious medical consequences. And it is a really prevalent disease. So in Canada alone, over 50,000 patients are admitted every year into hospital for stroke care. And globally as well, it is the second leading cause of disability-adjusted life years. So what you might not know is that swallowing disorders are one of the most common post-stroke complications. So why does this happen? Well, the pathways in the brain that are involved in swallowing are complex. They consist of supratemporal pathways in the cortex, as well as key central pattern generators in the brainstem, particularly the medulla. So during a stroke event, these pathways can become disrupted. And so as a result, there can be serious consequences for a patient's swallowing. It's estimated that up to 55% of post-stroke patients have trouble swallowing, or what's medically known as dysphagia. And dysphagia is serious because it can increase the risk of aspiration pneumonia by up to 3 times. And aspiration pneumonia occurs when there's fluid that enters the lungs and is this another serious cause of mortality in post-stroke patients. So hopefully I'm painting a little bit of a picture of why it's so imperative, of why we assess for and diagnose dysphagia early on in the clinical course of a stroke patient. And another important thing to understand this project is that the neural pathways that underlie swallowing are also involved in speech. So as a consequence, patients who are dysphagic also often have issues with their speech, also known as dysarthria. So how do we actually assess for swallowing disorders in post-stroke patients? Well, the gold standard is what's known as video fluoroscopy, and it involves patients swallowing a radioactive substance, most commonly barium. And while they're swallowing the substance, we take an X-ray and we can see where the fluid ends up. So in a normal swallow, most of the fluid should go, or all of the fluid rather, should go down the esophagus. And when there's abnormal swallowing, you'll see that some of the fluid actually goes into the trachea, which is not good. And so video fluoroscopy, although it is the gold standard, it has a number of limitations. The first of which is that it involves X-ray and radiation. Although it's relatively low doses, it's still a consideration. Oftentimes, where this test is performed is not in the stroke unit, it's somewhere else. So you have to transport patients. And there's also cost involved. You need dedicated space, you need dedicated technicians to perform the test. So as a consequence, what are often used clinically are actually just screening tools. And one of the most common of such screening tools is what's known as the TORBEST, or the Toronto Bedside Swallowing Screening Test. Now, these screening tests are great, but they also present some issues. They're time-consuming to perform. They have to be completed by trained personnel. And probably most importantly, there's an element of subjectivity. So you ask patients to swallow some liquid, and then you ask them to either cough or say a word. And it's up to the trained person to determine whether the change in one's voice might belie an issue with swallowing. As well, there's risks to patients. So in a place like Sunnybrook, you can usually administer Torbest relatively quickly. But in places under resource settings, for example, patients will have to wait for this trained personnel to come and administer the test. And while they're waiting, they're on what is known as NPO, so they can't have any food orally. And during this time, that can present many issues for patients' quality of life. It can lead to nutritional deficiencies. And so we really want to try to assess for dysphagia as quickly as possible. So that leads me to the motivation for this study. And the idea is that we think we can diagnose, or at least screen for dysphagia directly from voice changes, rather. And the primary objectives are to develop a classifier based on this voice analysis and to decrease the subjectivity involved in dysphagia screening. So what we did is we collected vocal samples from patients. These consist of vowel sounds, sustained vowels. Additionally, when a patient is admitted to hospital for stroke, they're administered what's known as the NIH stroke scale. So this is primarily a cognitive assessment for stroke, but it does have language and speech components. So it presents a prime opportunity for us to collect vocal samples. And with all these vocal samples, we want to either classify patients as having disordered swallowing, so a fail, or having normal swallowing, a pass. And these labels are from the Torbest, so that screening test that I just discussed. So we collected data at Sunnybrook Health Sciences Center on the neurovascular ward. We collected data from 70 inpatient post-stroke patients with a median age of 70, and this data collection occurred from August until March, August last year until March of this year. And in total, we had over 1,500 audio clips consisting of NIH speech samples and vowel sounds. So the data we collected from patients was vocal samples. So we have a microphone, we collect their voice, and we generate an audio signal. However, we actually want to turn this audio signal into an image. And this is for a number of reasons. The first is that we can actually leverage advancements in computer vision that have occurred over the past decade and use existing models. So we can sort of use our smaller data set and use more powerful models for that. And this is an approach that is being used in other areas of audio classification. So for example, genre detection in music, as well as bird sound classification in sort of ornithology. So how do we actually do this? Well, we take our audio sample and then we perform what's known as a fast Fourier transform. So this decomposes the signal into a frequency domain. And you can actually get the magnitude of the frequency domain as such. And when you take different windows, you can determine the magnitude of the signal at different times, and you can use that to actually generate an image. So the image we generated here is a Mel-spectrogram. So it's a spectrogram, so frequency components over time, and the y-axis, so the frequency magnitude, is actually normalized onto what's known as a Mel scale. So it most closely resembles how humans actually hear sound. So what we did then is we slide a window, a 0.5 second window, across the audio signal, and we can generate many of these Mel-spectrograms for even a single audio clip. Now, when we're representing this audio clip in this magnitudes, we're using it, in our RGB case, we're using a scale. It has red, green, and blue. And so this image, although it's 2D, actually is a 3D array, which consists of red, green, and blue, which is like the magnitude representation here. So because we're using a 3D array, we also experimented with actually using the depth, so the three different channels of red, green, and blue, to compute different Mel-spectrograms. So for instance, the blue channel, we did a Mel-spectrogram of 1024, the green channel 2048, and the red channel 4096. And when you concatenate those different channels together, you can produce a different image that we input into the network. And this image actually contains more information because it contains different NFFT lengths within it. Okay, so next we actually went to the classification step. So we used a convolutional neural network. And just as a very quick overview, convolutional neural networks consist of multiple layers. Generally, they have these convolutional layers, which you can see here. So you're passing a filter across an image, and that filter is able to detect shapes, edges, and as you train your backpropagate through the network, it's a really effective way to learn hierarchies within the image data and is quite exceptional for visual pattern recognition. So the networks that we use two networks, and both of them are quite novel. The first one is DenseNet. So DenseNet consists of 427 layers. What's kind of unique about it, it has these feed-forward connections. So every layer has a connection to every subsequent layer. And so the advantage of this is it lowers the number of parameters involved, and it improves the propagation of features through the network. And we use this network because it's been shown in recent literature to exhibit superior performance in image classification tasks that are based on audio data. And another novel network that we use is ConvNeXt-Tiny. So this is another convolutional neural network. What's interesting about this one is it actually aims to mimic the performance of vision transformers using patchfly layers and larger kernel sizes. The advantage of this over directly using a transformer is it has a much smaller number of parameters. Okay, so now I'm going to provide a little bit of background on transfer learning, and hopefully this is educational to some of you. So this is a sort of representation of a neural network. And when we do transfer learning, we take a subset of the network and we freeze the weights. Then with the unfrozen layers here, as we go through the epochs and we backpropagate and update the weights, we can update only the weights of the layers that are unfrozen. And as we continue through training our network, at the end, we have a network that's trained with the frozen weights that are the same and the unfrozen weights that are now updated based on our data. So why do we do this? Well, these big networks such as DenseNet and ConvNeXt are trained on ImageNet, which consists of millions of images. And those networks are trained on images like cats and dogs, but that's obviously not what we have. We have a Mel-spectrogram. So we need to fine tune the network to be applicable on our types of images. And on ours, so let's look on DenseNet, well, we froze layers up until block 3, and on ConvNeXt-Tiny, we froze layers up until stage 3. Okay, so now I can move on to the classification. So a single patient will generate many audio files, and from these audio files, using those windows I discussed, we generate many of these Mel-spectrogram images. For each of these images, we produce a classification output. So we can either say if they're a TOR best pass, so they don't have a swallowing disorder, or there might be a fail. And for each of these labels as well, we generate an output probability. This output probability corresponds to the confidence that the network has for a given classification. So for example, 0.9 means it's more confident that this clip came from a pass patient, and 0.4 means it's closer to 0, so it's more likely to fail. Now, this is what we call clip level classification, but what we're really interested in is classifying a patient as either a pass or a fail. So to do that, we just take the average of all these output probabilities and we generate an outcome probability here. And this is participant level classification. Now, to reduce some of the bias and variance in our models, we also leverage a technique called ensemble learning. So we have two networks, the DenseNet and the ConvNeXt. So you can train one network and then have it output a probability for a participant. And then you train another network to do the same. And you actually fuse the outputs here into one probability. And this is an effective way to reduce variance that results from differences in local minima that occur during the training process. So going on to results, here are some of the training and loss curves for DenseNet and ConvNeXt. You can see we had good convergence. We used the learning rate scheduler to try to reduce some overfitting given our relatively small data set. And we had only trained it for a short number of epochs. So in terms of the results, DenseNet performed well. On the clip level, it had sensitivity and specificities of 0.77 and 0.63 respectively at the clip level. And on the participant level, it could identify fails with a sensitivity of 89% and a specificity of 79% and an AUC of 0.88. ConvNeXt-Tiny also performed similarly. So here on the clip level, we had sensitivity and specificities of 0.63 and 0.76 respectively, and the sensitivity and specificity are 0.78 and 0.89. So what we did, as described, is we actually fused those networks together. So on the clip level, you can see that our AUC has been bumped up significantly. And on the participant level, we ended up with similar performance, but the AUCs also increased 0.9 and F1 scores improved here. So it seems like the fusion step is an effective way to sort of reduce some of the variability in the networks. Now, comparing the RGB and the 3-channel Mel-spectrograms, we didn't find a significant difference in performance between the two approaches. In fact, using this RGB images seem to produce slightly better results, but this might just be due to the fact that we have a limited amount of training data and increased information that comes from the 3-channel Mel-spectrograms. We can't effectively leverage it given our smaller data set. Okay, so in conclusion, we've demonstrated the ability to screen for swallowing dysfunction in post-stroke patients. We've performed the study in a real clinical setting, and with sensitivity and specificities of about 89 and 79% for detecting potential dysphagic patients. And in terms of our next steps for our study, we want to continue to expand recruitment, as well as explore state-of-the-art approaches such as vision transformers. And increasingly, there's some interest now in using transformers that can directly take the audio signal, so it would reduce some of the feature engineering involved. We also want to look at continuous and spontaneous speech, and there's more focus recently on potentially using voice as a kind of like general health marker. So there might be other neurological disorders that we could apply these techniques to. So that'd be something that's really interesting to explore as well. So I just wanted to acknowledge Nicole and the Khosravani lab, particularly Dr. Khosravani, for all his support and guidance through this, as well as Arjun, who's a resident in neurology, who has been a pivotal part of the study, as well as our new summer students, Hamza and Abtahal, who have really contributed a lot. So with that, I can take any questions.
That was awesome. I think you have a question already, so I'll let Tamara take it away.
Okay, I was wondering, you focus on post-stroke. How about screening people who have some kind of weak signs, and you can do the same tests or new tests as a precursor diagnostic, as a warning? Not post, but pre-stroke, potentially pre-stroke.
Do you mean to actually detect or predict the onset of stroke, or predict the onset of the swelling?
Yeah, suppose somebody has many years of high blood pressure. Maybe they have a swallowing problem. Maybe they have a voice hesitations, up and downs at times. If you even did the same sequence of tests that you described for post-stroke, maybe you can give the person a pre-stroke warning. And then maybe the doctors can say, okay, you're a candidate for that. Be careful of A, B, C, D. Preventative.
Yeah, that's an interesting idea. And you'll see in the literature now increasing interest in actually using voice as a general marker for health, even in areas where you might not expect, like things like dementia or cognitive performance. You can use voice as an indicator for that. So I think in the future, for sure, there'll be opportunities to use this to hopefully detect early on in a clinical course to be able to have some more preventative measures.
Great. May I follow with another?
Maybe we'll give opportunity for everyone to ask one question,
sure.
and we'll come back. That's okay.
Of course.
Perfect.
Yeah, sure.
I'm excited by all the discussion that this has stirred. Jethro, I think you raised your hand.
Yeah. Hey, Rami, excellent work. I do have a couple of questions, but maybe I'll just start with one of them. Right now, it looks like your label is based off of like the Torbus score. And I guess my question is like, what's like the variability? Like if, one person administers a Torbus score versus the other, what's the variability in the result? And secondly, like, was there any thoughts about like using actually like the results from the video fluoroscopy instead, if that is the gold standard?
Yeah, that's a great question. I mean, something we've also thought about. So just for the clinical practicalities, because not every patient gets a VFSS and it is like a little bit invasive, we use the Torbus as a label. But you're right, like there's variability in how it's administered. And there's also variability in, for example, like clinical course. Like if someone's administered a Torbest at one point, like maybe they get better the next day, or so that's kind of just like a limitation of the study, to be honest, like how we've done it. We wanted to do it on the ward and use like the information that's available on the ward. But in the future, it'd probably be a good idea to get like the gold standard VFSS and compare to that. In fact, I honestly, like, I guess it's a little bit of a biased opinion, but I think that would probably result in better results, because there's patients who maybe like they err on the side of like caution, I'd imagine, like the SLPs or the health professionals who are administering the Torbest, just patients who maybe are labeled to fail, but they're actually like, if you did a VFSS, would be okay. But
Yeah.
Okay. That's a good point.
All right, Armand, do you have a question as well?
Yeah, thanks. Just great talk. Really enjoyed it. I just was curious. I know that the sample size was around 70 patients, so you're probably limited in your ability to explore misclassified cases. But were there any patterns you saw in terms of locations of stroke or type of stroke, and sort of how the model performed?
Yeah, that's an excellent question. You have to stay tuned for our paper publication for that. That is something we're exploring. Like we've gone into the sort of like EMR to see location of stroke, and then we'll do some analysis on that dimension. But unfortunately, no, I don't have the answer to that. But I can get back to you.
Look forward to it.
On a related note, there was a question in the chat about that 70-person sample. If you're able to speak a bit to the diversity and who's captured in that.
Yes. Yeah, I don't have that information in this slideshow, unfortunately. My apologies. But yeah, there's the ages that are listed here. That's demographic information is also something like, as we go through the EMR, where it will be part of the paper. So I'll have to follow up on that.
Sounds good. And Mo, did you have a question? Oh, I think you're muted.
My apologies. Can you hear me now? Yep. Great. Thanks, Rami, for the great work and for developing this but non-invasive method to diagnose swallowing disorders. And thinking about this for a second, I wonder if you've considered sort of external validation of this neural network, and especially on like on a separate data set of patients with swallowing disorders that are not stroke related, but neurological, things like Parkinson's disease, for instance.
Yeah, that's a great idea. I guess the challenge in sort of this kind of external validation is just finding those data sets. But if you know of any, would be happy to see if this works on that. Yeah, I think there's other maybe opportunities for increasing explainability. Like for our paper, we're hoping to maybe do some like integrated gradients on the network to see which parts of the images are being classified, and sort of like, hopefully with that kind of justification, we'll be more certain it will transfer to other applications.
Thanks.
That was awesome. All right, we'll go for some repeat questions. So Tamara, you had a question that you also wanted to ask?
Yeah, I was wondering, we're talking AI, and it looks like the AI is serving so many different fields, but if we're talking about the medicine and medical data, how about, is anybody looking at medical subject matter guiding new AI methodologies and algorithms? Not sure the question is clear, but you see, there is a whole toolkit of AI methods available. So all one needs is to collect data, certain data, and turn the wheel, and you get results. But maybe these results may be much better refined and geared to the subject matter, which is now medical data.
I understand your current American talking about 2 points, perhaps you're like touching on. One is like the potential to sort of find better techniques and how like applying those techniques to medical data. I think one of the issues is like bottlenecks on data, like for obvious reasons. There's like privacy considerations for health data. And so it can be hard to, there's so much data available in like EMRs and such, but to actually use those data in research projects, there's like some complications there. So hopefully we can sort of like find ways to use those data in the future, because I think there's a lot of opportunity. But then I think the second issue is just around like knowledge translation. So you know, if you search on like PubMed or AI in medicine, you'll find like just a ton of research, but how much of that research actually gets used clinically is a tiny fraction of that. And so hopefully like with something like this where it's very like clinically applied, we will try to like bring this to a point where it will be used clinically. And I think there probably just needs to be like support for researchers in translating that into the real world. I don't know if that answered your question at all.
Okay, thank you very much. Great talk.
And great question. You could have done a whole talk on that probably. All right, we'll take one last question from Jethro.
Okay, I'm sorry if you may have mentioned this earlier, but like how was the data set split into like your training and validation? Was it like, what was like the percentage, or how did you guys do it? And then also, was it split on like the sample level or at the participant level?
Another great question. So we split on the participant level. We just did like standard 60% training, and of that 20% was validation, 40% was dedicated training. And then, yeah, the other 40% of the larger participant data set was used for test. And what we also did was the test set is actually like, it was separated chronologically. So the last 40% of patients that we collected from were dedicated to test set. And that's kind of just like to mimic what would happen in a clinical setting if this was actually applied. But that doesn't mean that there's like an imbalance in the data set that's just inherent to the clinical condition. Good question.
Awesome. Well, thank you so much for your talk and for explaining the clinical relevance. I think it's very clear like where your research fits into medicine. And so that's always very exciting. So one more round of applause for an excellent presentation. Virtual round of applause. So now we will hear from our next speaker. Sorry, my computer froze. All right. Yeah, so our next speaker, Ruiyan, we're very excited to have her today. So she comes from a similar biomedical background, but did her undergrad in Hong Kong. And we're excited to have her now at the University of Toronto while she's doing her PhD. So she's worked on deep learning and medical imaging analysis, and her PhD is focused on auto-contouring of normal organs and tumor targets. So I'll let you take it away, and I'm excited to hear the presentation.
Okay, thank you for the introduction. So hello, everyone. Thanks for having me here. I'm Ruiyan, and I'm currently a second-year PhD student in medical biophysics. And today I will be presenting my project on auto-segmentation for targets and organ risk in cervical high-dose brachytherapy via deep learning approach. And this project I'm presenting today is part of my PhD thesis. So let's start with the background and project rationale. Cervical cancer is the fourth most common cancer in women, and over 600,000 women are diagnosed with it each year. Cervical cancer occurs disproportionately higher rate in less developed countries, that 9 out of 10 deaths occur in low and middle income countries. And the low mortality rate of cervical cancer is found in the high income countries due to adequate screening and effective cancer treatment. And therefore, it is very important to remove the barriers of offering cervical cancer treatment in developing countries. Radiation therapy is a standard treatment for cervical cancer, and 2 types of radiotherapy are frequently used, which are the external beam radiation therapy and the internal beam radiation therapy, as well as known as brachytherapy. The major difference between them is where the radiation comes from. As suggested by its name, external beam radiation comes from the machine outside the body and penetrates the patient from outside in. As for brachytherapy, the radioactive material is placed inside the patient's body via catheters to provide high concentration of radiation centered on the tumor region while sparing and protecting the surrounding normal tissues. So increasingly, we learned that combining these two methods is more effective in improving survival and local control of cervical cancer than just using external beam radiation therapy alone. Also, as shown in the left figure, even compared with some boost-dose EBRT like IMRT and SBRT, brachytherapy boost can still have a better survival rate for cervical cancer patients. Therefore, we can say that high-dose brachytherapy is an important component in managing cervical cancer. However, in spite of the evidence of improved survival rate, brachytherapy is often underutilized due to lack of clinical resources and expertise. To better understand the obstacles of offering this treatment, let's look at the treatment procedure. And here shows the entire brachytherapy procedure at Princess Margaret Hospital, which can be divided into 3 parts: the preparation, real-time planning, as well as treatment delivery. So the entire procedure usually takes 3.5 hours on average, which is a pretty long time, and therefore there's a need to shorten this treatment time, as especially patients are under anesthesia during the entire treatment. So among these 3 parts, we can say that the time of the second part seems to be the easiest one to shorten, as they're all computational work. And in this project, we specifically aims to reduce the contouring time, which usually takes 45 minutes to an hour manual work from the radiation oncologist. And we want to have a fast and accurate OER and tumor target contours, as the accurate contour are the basis of having an accurate radiation plan to ensure sufficient dose is delivered to a proper tumor region while protecting the dose, minimize the dose to normal organs. The region to be segmented include organ risk and radiotherapy targets. And the OER for cervical brachytherapy consists of bladder in yellow, rectum in brown, sigmoid in blue, small bowel in blue, and also sigmoid. And the radiotherapy targets include gross tumor volume, GTV, high risk clinical tumor volume, intermediate risk clinical tumor volume, which are labeled in purple, red, and green here. The main takeaway here is that the OER contours usually only based on the scan taken during the treatment, which is the brachy scan. But the target contouring is a much more complicated process, including contour based on the brachy scan as well as the diagnostic information and the clinical exam notes. So in this presentation, I will be presenting the method to segment OER segmentation and how to ensure a highly accurate near to target OER contours. So because my project is highly driven by the real clinical needs, so let's go back and take a look at what really happened when oncologists draw an OER. As mentioned before, accurate treatment planning is the reason why we need accurate contours. And because the OER planning is driven by the OER dose to 2 cubic centimeter D2cc, which you can see here is the blue region in this sagittal view figures. And in this image, the target or where the tumor locates is labeled in the red star. And for each organ, we can see the D2cc region is the blue part, which is near to target in each OER. Therefore, only the near to target OER region are critical for treatment planning purposes. And in real clinical practice, oncologists pay more attention to this approximate region when they draw a contour. And therefore, we want our deep learning algorithm to have the same high segmentation accuracy of OER close to target. The way I use in my study is to tune the loss function. So first, we want to create a distance map to label which voxel are near to target. As the first step, a distance transformation is calculated with high-risk CTV, which is where the tumor locates, as the center. And this map labels each voxel of the image with the distance to nearest CTV boundaries. And the second step is to take the inverse square law so that the higher voxel value, the closer it is to the target. And the map is normalized to the range of 0 to 1, and it is further used as a distance map to penalize the loss function in the following step. So please note that although I'm only showing the 2D slides here, in the real practice, all the calculations are conducted for the 3D volume. As for the loss function, we use two commonly used loss function for image segmentation tasks as the baseline, including the cross entropy loss, which calculates the cross entropy between the ground truth and network prediction, as well as the dice loss, which is a region-based loss. And by training with dice loss, we can directly optimize the dice similarity coefficient. So first, we penalize the cross entropy loss with the pre-calculated distance map term DC here. And in this way, the voxel near to a tumor target will be assigned a larger weight during training. Similarly, the distance penalized dice loss was proposed by weighting the dice loss by the pre-calculated distance map, also the DC term here, aiming to guide the network's focus towards near to target voxels. So that is what we want to compare the loss with or without distance penalty. To reduce the training instability, we couple the dice loss with the cross entropy loss, and therefore the baseline loss become the combo loss, and the other comparison is to compare the distance penalized combo loss. Therefore, in this study, we would like to compare 4 models trained with 4 loss functions that are penalized with or without the distance penalty term. Let's look at the experimental detail on the slides. 170 T2 weighted scan from 55 patients were used, which were scanned by the 3 Tesla scanner and had a Ruiyan tandem applicator inserted. And the region of interest we are going to segment include bladder, rectum, sigmoid, and small bowel. 150 cases were used for 5-fold cross-validation during training, and the other 20 cases were used for testing purpose. So we use a 3D UNet as the neural network, which has the contracting path on the left and expansive path on the right. And the training is conducted under a self-configuration pipeline for image segmentation task called NNUNet. Here we included 2 standard evaluation metrics to test the network performance, including the volumetric dice similarity coefficients, which calculates the overlap over a union of predicted contour and the ground truth segmentation. And closer to 1 indicate better segmentation performance. On the other hand, the maximum horse-off distance is the maximum distance of a site to the nearest point in the other side. And the 95% horse-off distance is based on the calculation of 95th percentile of the distance. And the goal here is to minimize this distance. So more importantly, and most exciting part about this project is that we proposed a new metric being derived from the original dice to directly correlate with the new loss function. We call it the weighted DSA score. And this is the equation of how we calculate the weighted DSA. It looks overwhelming, but don't worry, I will walk you through with an example. Here is the pre-calculated distance map we introduced before, and it has a value range of 0 to 1. And let's assume here we want to threshold the distance map by 5 times, meaning that the step size will be 1 divided by 5 equal to 0.2. And therefore, the threshold value T here will be 0.1, 1.0, 0.8, 0.6, 0.4, and 0.2 respectively. In this example, we take the threshold value T equal to 0.6 as an example. And this gives us this binary mask showing that the region that has distance value of 0.6 to 0.4. And then it will be overlaid on both ground truth and the prediction contour to get the cropped regions for both the ground truth mask and the prediction. And then we calculate the original dice score between these 2 cropped volume. And as I mentioned before, the higher the threshold, the closer the cropped region it is to the target. And the more penalty, therefore, will be given if there is a region difference between these two cropped volumes. Therefore, in this case, when the threshold value t equal to 0.6, we want to penalize the loss of original dice with the distance value, which is 0.6 here. And this distance penalized loss of original dice equal to 0.6 times 1 minus the original dice. And extending that to many thresholding value, we finally calculate the weighted DSA score, and it is computed as 1 minus the total distance penalized original dice loss. And the latter part here compute as all the sum of all the thresholded regions divided by the time it takes. Like here is n. So ideally, we want n to be infinite so that the cropped region will be infinite thing that will give us a continuous measurement for the distance. But in practical, we assume that n equal to 100 can provide a decent estimation. So we want to examine whether this new metrics can be better correlated with the clinical performance. So the relative D2CC difference is what we use here as the reflection of those difference. It is calculated by applying the clinical treatment plan to the auto contour to calculate the D2CC PRED value, and minus the prediction D2CC by the clinical D2CC and divided by the clinical value times 100% gives us the relative D2CC difference in percentage. So in this figure, we show 4 different OERs, and the x-axis of all the figures are the relative D2CC difference percent, and the y-axis is the weighted DSA score. So we plot the scatter plot for each component and did the linear regression. And based on the R value of the linear regression, we can say that in the most scenario, there is a moderate to strong correlation between these two parameters, showing that our new metrics, the weighted DSA, can be used as a pre-evaluation for dosimetric acceptance. Here is the network testing result, and the image is examined by the weighted DSA score. So as we can see here, for 4 different organs, the 4 boxes in each plot is from left to right represents the model trained by the cross entropy loss, the distance penalized cross entropy loss, the combo loss, and also the penalized combo loss. So if we only look at the orange group, the cross entropy based group here, we can see the darker box shows a better weighted DSA score for all the organs, but the only statistical difference is detected for sigmoid. On the other hand, if we look at the blue group, which is the combo loss based result, we can see the darker box again. The penalized combo loss have a slightly better performance than the baseline loss, and the only statistical difference is detected for the small bowel. So here is the conventional evaluation matrix result. The first row is the original dice, and the second row is the Hausdorff distance. We can see there's no difference, or all the loss gives us a very comparable result. The only difference is detected for the bladder and rectum between the cross entropy and penalized cross entropy. But as these 2 organs the results are pretty good even for the baseline, we don't consider it as a big improvement. Here shows one real case example. So the 5 column here shows from ground truth mask, and followed by the prediction by the 4 different loss functions. And here we're showing 2 easy to segment organ, bladder and rectum. We can see all the prediction results are very similar compared to the ground truth. And if you look detailing into some of the slides, the last penalized combo loss gives a slightly better result for some of the details. And here are the two harder to segment organ, the sigmoid and the small bowel. Again, for the sigmoid, the cross entropy loss performs the worst, but the rest three of them have pretty good results aligned with the ground truth. And the small bowel is where we can have a noticeable difference. Compared to the ground truth, the penalized combo loss gives us a best result compared to the ground truth mask. So to sum up, in this study, we proposed a new evaluation metric called weighted DSC to directly correlate with the dosimetric parameter, the D2CC difference. And second, the distance penalized dice plus cross entropy loss had slightly outperformed the other loss in the near to target OER segmentations, especially for the small bowel segmentation, which is the hardest organ to be segmented. And this study addressed the real clinical needs for OER contours and will help to further generate more optimized treatment plan. In the next step, first we will keep improving the distance penalized loss and followed by the dosimetric and clinical acceptability test. And in the future, we want to integrate this model in our in-house pipeline for patient treatment. And in the end, I would like to express my thanks to my supervisor committee member, lab members, and funding support. And thank you for listening. I'd like to take any questions.
Thank you, Ruiyan. That was an awesome presentation. And so yes, we do have about 10 minutes for questions if anyone has a question that they'd like to pose. Jethro?
Can you guys hear me? Yeah, okay. Great talk, and this is very, very interesting, and congrats on like working on this new evaluation metric, and certainly it seems very clinically applicable. I'm wondering, like right now, the example that you've given is in the space of like cervical cancer. I don't know if the lab has access to, other patient types. So for example, like prostate cancer, similar region, like can this metric be applied in other cancer types?
Yeah, thanks for the question. It's a great question. So because we are focused on the brachytherapy only, which requires the source is a point source. That's why we have the distance penalty loss function specifically proposed for this usage. And so currently we only have our lab only working on the cervical cancer and gynecological cancer. But as you mentioned, you are correct, like it can definitely be applied to prostate cancer. But like the weakness, like not the weakness, but the short side of prostate cancer is that the OER is easier to be segmented. That there's only prostate, the bladder and rectum. And as also showing our result, bladder and rectum are very easy to be segmented. And they don't care about many hard to segment organs. And that's why we find this work maybe value more for the gynecological application.
That was an excellent answer. That makes a lot of sense. Elliot, I believe, also has a question.
Thanks. Great talk. It's a very hard problem, so it's interesting your take on it. One small point. So I like these pictures, but it's very hard to see the differences between like the ground truth and the other options, like where they lose out. So it might be better to overlay them so you could see which parts of the image actually correspond to the ground truth and which parts fall out, just so you can see it at a glance where these things go right and wrong. Small observation.
Yep, that's a great suggestion. Thank you. We had the overlaid contour before, but since there are like 5 comparisons, I feel it may be a bit mess if we plot 5 contours in the same plot. But yeah, we'll
also
figure out
thinking
better.
5 on the same plot. For each one, you could look at individually. So just like the ground truth and like the CE loss and the ground truth and the ground truth versus whatever you're looking at, basically.
I see. Yeah, that will be better. Yeah, I will take a look. Thank you.
Okay.
Okay, may I?
Yes, absolutely.
Okay. For many years, I know about the external radiation. There was a lot of collaboration between MIE department at UT and PMH about optimization of the dosage and the consideration of neighboring healthy tissues and so on. But that was dealt as purely optimization problem and helped Michael Milosevic and everybody. And the question is, when you do, there is a big name here, Buck, whatever, that you do it internally. And yes, of course, you consider the other organs, but maybe some of this optimization approach by the MIE people could be useful here. Like you had a beautiful mathematical development of this distance function and loss function and so on. And that's admirable, that's fantastic. But there is body of work that's done about the external radiation as optimization problem with objective function and so on and constraints. Maybe it's useful here.
Yes, for sure. Like there's plenty of work and a lot of work can have been done for the external beam radiation, and there's a lot of excellent paper have been published. And I know a lot of institutions, even PMH, we have our own like optimization in-house pipeline, and that's why we are like, yeah, we're trying to kick out on the bracket side, because the data is the application actually is much harder and we have less data and there are not enough research have been published in the bracket field. And that's why my project is trying to fill this research gap. But I don't know if that answers your questions or.
The question is, if you had a chance to consider that work that was done successfully on the external radiation, maybe some of that wisdom can be useful for much more complicated internal radiation.
Oh yeah, for sure. Because because in the external beam, we care about the boundary, and some like a study from our lab actually found like Hausdorff distance, like the boundary distance difference correlate better with the clinical acceptability. And I think that's the same idea at what we are trying to do here. So instead of considering the entire boundary, we only care about the boundary like near the region and boundary near the target, because of the different nature of like where the radiation comes from in the external beam or the internal beam. Yeah.
Okay, thank you. Great work. Thank you very much.
No worries. Thank you.
That was excellent. And we might have time for one last question if anyone has one. Okay, if not, I'm sure anyone with questions can contact you. So I want to thank both the trainees for their amazing presentations today. Rami and Ruiyan did a phenomenal job explaining their work in AI and how it interfaces with medicine. And I feel very inspired and excited after hearing both of your presentations. And thank you to everyone for attending. That concludes today's meeting.